I'm very happy to be here with you today to talk about an important topic, depression in cancer patients. We've already heard from other speakers today, especially Dr. Murphy, about the importance of this as a complication of cancer and its treatments, and so we'll spend a good bit of time on this here today. I want to take a very practical approach, a very kind of how-to. The subtitle of this talk is How to Use Antidepressants for Patients with Cancer. And so, in a way, it's kind of like a psychopharmacology fellowship in a can. We're going to cover some real practical how-to things. I have no relevant financial conflicts to disclose, unfortunately. I wish I had more financial conflicts to disclose, but I don't right now. I will refer to off-label use of medications, particularly when I talk about stimulants, if time allows, for depression in this patient population. And I think PowerPoint is a great tool, mostly for delivering cartoons. So I have a cartoon that's really more about. It fits more for my Breaking Bad news talk than my depression talk. But this is one of my very favorite cartoons, where the little pig is coming to the doctor and is being told the bad news: "It's your ribs. I'm afraid they're delicious." Has nothing to do with depression, really, other than that would be a pretty depressing thing for a little pig to hear, I think. All right, so here's what we're going to talk about there. We have more slides than time, and I realize that I'm the only thing standing between you and lunch. Okay, so I'm going to cover some of the highlights of this talk. But what I've tried to do with the slide set is create them so that they're pretty standalone. They're in frequently asked questions format and pretty practical. So particularly the depression management slides, I think, will still be valuable even if we don't get to cover them in real time here. We're going to focus on detection and management. And those slides that I may not really go in detail come pretty directly out of the American Psychiatric Association's treatment guideline, which is a very good treatment guideline for clinical depression, for major depression in general. Doesn't say especially much about depression in the setting of medical illnesses like cancer, but I think in terms of certainly the medication management, it really is pretty generalizable to even the populations that we care for. So we'll talk a little bit about what's different about depression in the setting of cancer, how to screen for depression, some of the evidence about whether or not antidepressants work. There's a good bit of information in the slide set again about the practical management and some cautions. And then this is just an outline of the topical areas that we'll cover, and we'll get to as many of these as we can. When you think about the problem of depression in patients with cancer and sort of the scope of the problem and the prevalence of mental disorders, there's now a sort of an aging study done in 1983 by a group led by Derogatis. It was published in JAMA, but it's still really one of the best snapshots of the prevalence of mental disorders in cancer patients done, because this group went to a lot of trouble to look across cancer cell types, across stages of illness. So they didn't just get a convenient sample of folks who were sick enough to need to be in hospital or folks who were in active therapy. They looked at folks who were post-treatment. They looked at folks who were ambulatory. They looked at folks who were really sick and in hospital. And that's an important confounder to control for, because there's a very close direct correlation between having a medical illness and the severity of one's medical illness and the likelihood of having depression and anxiety. So a lot of the prevalent studies in cancer patients are really confounded by the fact that they're a convenient sample and there's a good bit of selection bias. But these folks did a really nice job going across the whole spectrum of cancer patients. And what they found is that a little more than half of the folks in their sample did not have a diagnosable mental disorder. And this is long enough ago that this was DSM-III and not DSM. We're currently in DSM-V, the fifth revision of the Diagnostic and Statistical Manual of Mental Disorders. But in terms of mood disorders, they're still diagnosed essentially the same. And most of these categories, there haven't been sort of major revisions in the diagnostic approach. But about half of folks really didn't have any diagnosable mental disorder, but a third of patients had what it was classified as what's called an adjustment disorder. We'll talk about that in some detail in a moment. 6% of folks had a depression, a diagnosable clinical depression. That's not, in this sample at least, that's not very different than the point prevalence in the general population. So this particular study doesn't support a higher rate of full-blown clinical depression, but it doesn't. It's still a substantial burden in the folks who do have that. The organic disorders are things like delirium. The organic brain disorders is an old term for mostly cognitive disorders, including delirium. Personality disorders and anxiety disorders were very low. Actually, as a category, anxiety disorders are the most common category of mental disorder in the general population. I suspect a lot of what presented as anxiety and depression got captured in this net here, in the adjustment disorders. The adjustment disorders are really reactions that are often predominantly present with anxiety and depression to an identified stressor that don't quite meet the threshold for a full-blown mental disorder. Now, the name adjustment disorder is unfortunate, I think, because the name to the person who's not a specialist in this area sort of implies a treatment, doesn't it? Well, just adjust. You have an adjustment disorder, So the name itself kind of trivializes this situation. But I'm sure those of you who, you see cancer patients, I'm sure you've seen this over and over again. As Dr. Murphy pointed out, it's very common for the patients that we see who have a substantial burden of distress from depression and anxiety to really not have any premorbid history of a mental disorder. So they're not accustomed to dealing with depression or having to have treatment for that. And it's very distressing, very disturbing, very upsetting to someone's life. I'll never forget the day that I really figured this out. I was listening to a lady in Birmingham in my sort of consulting office, a lady with ovarian cancer who was describing this sort of feeling of having her whole life turned upside down, of feeling completely out of control, not knowing what the future holds for her health-wise in terms of her survival, in terms of her roles in her family and her community. And I said the magic word. I said, "It seems like your life is in a tailspin." And remember that scene from A Charlie Brown Christmas when Linus is playing the piano and he's plunking around, and then Lucy, when he gets the song just the way Lucy wants, she leans over the piano and says, "That's it," and he kind of flips in the air. This lady did that Lucy to me. She sort of leaned over the table and said, "That's it. That's exactly what it's like." So I started calling this syndrome tailspin, and it really resonated with a lot of patients. So even though in the psychiatric nomenclature, this would be viewed as a trivial subsyndromic diagnosis, and one that most insurance companies wouldn't reimburse a psychiatrist for, by the way, because it's not considered above the threshold of a real diagnosis. This is a very real diagnosis in cancer patients. This is the biggest part of what psycho-oncologists do. This is incredibly distressing and upsetting to patients who have cancer. Again, so what's different is they're often premorbid psychiatric history is unremarkable. They have existential concerns and fears. The other kinds of differences between folks who present with depression who don't have cancer is that patients who are struggling with cancer have existential concerns and fears about dying and suffering. There aren't very many illnesses. I would contend maybe AIDS, although that's lessening with some of the advances in AIDS therapy. There aren't other diagnoses that have the kind of emotional valence that cancer has attached to it. My mother is a 15-year breast cancer survivor. My father has multiple chronic medical illnesses that he lives with every day. My parents' neighbors think that my dad's doing okay and that my mom had cancer. So, but that's because of the emotional valence that these illnesses that we treat have for folks, and it causes a good deal of worry and concern and suffering and distress. The systemic effects of cancer and its treatment, including pain, fatigue, and nausea that we've been talking about during the conference. The side effects of other medications. The nervous system effects of inflammatory mediators. Dr. Murphy talked about that in some detail earlier today as well. The meaning of the physical comorbidities. Things like pain don't just cause suffering because they hurt, and because that pain pathway triggers the brain's fire alarm system or smoke alarm system. Pain's adaptive function is to tell you that tissue is being damaged and you need to stop doing what you're doing and pay attention to that. So it distracts your attention from other things. That's all part of pain. This is also the meaning of pain to a cancer patient. A patient with cancer who's having pain that we're having trouble controlling, they're worried that means we're not controlling their disease. Their disease isn't under control. So there's lots more to the suffering that pain can cause than just nociception and even the neuropsychiatric components of that pain signal. We see folks with changes in body image, changes in social role and lifestyle, and a number of financial concerns about dealing with an expensive and sort of role and often employment-limiting illness. So there are a lot of differences in patients with cancer who have depression than folks who are medically healthy. When should treatment for depression be started? And the answer to that is basically when the patient meets criteria for a depressive episode. I'm going to spend a few minutes sort of talking about ways to screen for depression, but certainly depression screening should be something fairly common in cancer care settings. And when patients cross that threshold, treatment should be considered and offered to them. Certainly also when depressive symptoms cause substantial distress. Those patients in that big category of adjustment disorders may not meet the full-blown criteria for a clinical depressive episode, but if those depressive symptoms are causing distress, then they need to be the focus of our care and attention. Certainly when we're in the palliative care setting, we need to be willing to palliate mood symptoms and depression just like we palliate other symptoms. Treatment here does not necessarily mean antidepressant medications, and certainly doesn't mean antidepressant medications alone. So I'll talk a little bit about that as well too. But just from the get-go, let's bear in mind that treatment doesn't necessarily just mean medications. And so to follow up on that, by show of hands, how many people practice in a setting where you have access to a psycho-oncology or mental health clinicians who are familiar working with cancer patients, somebody you can refer people to? I saw 4 hands. Okay. So there may be, the reality on the ground is you really may not have colleagues to collaborate with and refer to, and so that may mean that in some settings we're sort of relying more on things like antidepressants, so that's why there's a good bit of emphasis here. But know that the gold standard is integrating some of these other therapies, some of which are specialist level care and some of which all of us can do, so I'll touch base on those. But how do we make a diagnosis of a depressive episode? This is a little mnemonic for remembering the 9 diagnostic features of a clinical major depressive episode. By the book, if you have 5 or more of these 9 symptoms present for at least 2 weeks, more often than not present, then you can make a diagnosis. Now, if somebody meets these criteria and they've had these symptoms for 10 days, do you say, okay, come back in 4 days and we can make the diagnosis? No. You might say, come back in 4 days before I can enroll you in my research for my drug treatment trial. But if somebody's, it's clear that they have a persistent, mood problem, then you can go ahead and treat it. But these are the 9 symptoms, and a psychiatric ancestor of mine came up with this mnemonic for remembering these criteria. If back in the days when we used to write prescriptions by hand, you remember, you used to actually put the instructions under sort of the Latin, shorthand SIG, okay? So if you were going to prescribe for depression, which diminishes energy, you might prescribe energy caps or E-caps. So you might write on the prescription SIG E-caps. There's the mnemonic. The D in SIGI caps is silent, apparently. This is the thing that got left off the mnemonic. But that should be the easiest one of the symptoms to remember, a depressed mood or feeling of sadness. Particularly older patients are less likely to sort of come out and confess that. They may sort of present things with more somatic symptoms, but it's important just to ask about, are you having feelings of sadness or feelings of depression or feeling down? Sleep disturbance can be both difficulty falling asleep, but the classic sleep disturbance pattern in a major depressive episode is early morning awakening. I'm still tired. I've set my alarm for 6:30. I get up at 4 o'clock and I can't go back to sleep, even though I'm still exhausted. So your diurnal rhythm gets thrown off, and you generally don't have trouble falling asleep because you're exhausted at the end of the day. But then the classic pattern is early morning awakening. But you can sometimes see initial insomnia as well. Loss of interest or loss of libido. It's in older patients often, if I can't get someone to show some zest when talking about their grandkids, I get kind of worried about that. What are the things that you usually enjoy? Have you lost your interest or lost the ability to enjoy those things? It's a way to get at that question. Feelings of guilt, hopelessness, or worthlessness, lack of energy, problems with concentration, appetite disturbance, again, usually diminished appetite, though sometimes an increased appetite. Psychomotor disturbance, usually psychomotor retardation, which is just the loss of the normal kind of body language and tone of voice inflection, where folks get sort of flat affect and they don't really make good eye contact and they don't move their arms very much when they talk. Psychomotor retardation. Thoughts of death or suicide would be the last of those symptoms. So technically, if you see 5 or more of those symptoms for 2 weeks or more, then that's indicative of a full-blown major depressive episode. Now, problem. You all take care of cancer patients. Folks who are often physically pretty sick. How many cancer patients have you met, especially folks who are in active therapy, who don't have lack of energy, who don't have an appetite disturbance, who don't have some difficulty with sleeping, who haven't thought about death every now and then? Okay? So there have been lots of efforts to look at these criteria, and can we modify them for cancer patients? Can we come up with either an alternative diagnostic scheme, or we'll pull some of those neurovegetative sort of physical-like symptoms out and just use the subset of more psychological symptoms, or can we make a substitute expanded set of psychological symptoms? There's actually quite a bit of literature about that. The good news for all of us who practice here is that none of those have worked, so nothing predicts treatment response better than the garden variety sort of regular diagnostic symptoms for folks even without cancer. So that said, your confidence that you're dealing with a depression and not with the constitutional symptoms of cancer or its treatment goes up if you also see anhedonia or hopelessness, helplessness, or worthlessness, guilt or feeling of being punished. The disease that I have is punishment for something that I've done. I deserve this. Suicidal ideation, intense morbid ruminations, frequent tearfulness, expressed self-loathing. If you see more of these psychological symptoms consistent with a depression, that certainly raises your confidence that this is a depression and not the constitutional effects of cancer, its treatment. But again, I would encourage you, the literature really pretty strongly supports using those original criteria as they stand, and fatigue counts toward one of the 5 of the 9 criteria in cancer patients. Now, you can't, by the book, make a diagnosis of depression without having either depressed mood or loss of interest or libido. You have to have one of those 2 cardinal symptoms by this diagnostic scheme. You could technically have the other 7 symptoms and not be able to make the diagnosis. So you do need one of those, but the symptoms count. How many folks are familiar with the PHQ-9? Show of hands. This is rapidly becoming the gold standard for bedside, ambulatory clinic, home-based care screening for depression. It's a patient-completed questionnaire It basically takes those 9 diagnostic categories and gets the patient to rate them as, they never happen, they happen every once in a while, they happen pretty frequently, or they're happening all the time. And it's patient self-completed, it's easily scored, they're available free for use without a fee, as long as you don't modify the forms at this website. It's also at the end of your handout. They also have screens for anxiety, for somatic illnesses, but this depression screen, the Patient Health Questionnaire 9, PHQ-9, is rapidly becoming sort of certainly the non-psychiatric setting gold standard screen for depression. There are also guides about the final PHQ-9 score and initial treatment approaches. What to do if the score is 1 to 4 total, then just monitoring the patient. At 5 to 9, it's sort of mild depressive severity and watchful waiting and serial screens, and then sort of stepping up the therapy as the scores increase. So a really good and handy and pretty easy to use and apply screening tool that I would recommend to you. When you're looking in the setting of any physical illness, cancer included, and you're trying to decide sort of how to approach this, very important to look at the history of previous episodes. Is this a patient who's had, do they have major depressive disorder? Have they had depressive episodes in the past? There's certainly nothing protective about the stress of having cancer and undergoing cancer treatment that would keep you from having a recurrence. This tends to be a recurrent illness, so that would lead you to questions about, how did you get better? What kinds of treatments worked for you before? They're likely to work again if they're things that the patient can tolerate now. Very important to look for the temporal correlation to changes in general medical condition and treatment. As a psychiatric consultant in a cancer center, this is a big part of the job, is being the sort of diagnostic detective. What are the correlations? Because remember, these are, for the most part, folks who have pretty unremarkable previous psychiatric histories. You'll occasionally see someone who's got recurrent major depressive disorder and they've had a new episode. But we're really looking for now, what are the triggers? Did a medication get started? Did the medication get stopped? Is the patient really worried about dying? Are they having a lot of symptoms? Are they approaching bankruptcy? What are the kinds of things that may be triggering this? It's important to look at the substance abuse history, look for formal anxiety and depressive disorders, other factors which may complicate anxiety and depression in the medically ill patient, which was in the next slide. But I also want to make a comment about don't be taken in by the myth of appropriate depression. As a psychiatric consultant in cancer centers and general hospitals, I used to hear this often. I would see someone and they were depressed, and then would hear, well, John, that's okay. I think it's appropriate that he's depressed because he has cancer or he's acutely ill in the intensive care unit. I think we should really, if you're really talking about a full-blown clinical depression, this is not an expected part of these kinds of illnesses. This is a dread complication. I would actually, there was once that I sort of had to pull this out and use it. I sort of talked with a colleague who said, it's kind of like saying, you've got somebody who's in the surgical intensive care unit after a shotgun blast to the abdomen. You wouldn't say, well, gosh, of course she's septic. That's appropriate sepsis. If I'd been shot in the abdomen with a shotgun, I'd be septic too. No, you jump on that as, you now are developing sepsis and all the complications thereof as a complication of the shotgun blast to the abdomen. So, major depressive disorder and other things in this spectrum really are dread complications of cancer and its treatment is something we should take very seriously. There are a number of things to screen for that aren't depression or anxiety disorders that can look like depression. Patients who are angry at themselves, angry at God, angry at their situation, can sort of get withdrawn and look depressed. Anxiety and depression are very often comorbid, but they can also mimic one another. Some folks just have a quiet, withdrawn coping style. It's much more likely to be depression if it's a change in the way that they usually cope. Folks who are delirious but haven't really declared themselves to have a lot of cognitive disturbance or aren't agitated or actively hallucinating, can look, the so-called quiet delirium can really look depressed because they're withdrawn. Early stages of dementia, and dementia is often complicated by delirium. Simple discouragement, emotional numbing from feeling overwhelmed about their situation. It's important to distinguish depression and anxiety from fear. If someone has something they're particularly afraid of, then that's fear. Anxiety is more free-floating and doesn't really, it's just that feeling that you get, but there's not anything. But if someone's really afraid of dying or afraid of some other complication, then that's something to talk with someone about and not necessarily medicate. That's something to deal with as fear. Grief, interpersonal problems, that feeling of loss of control, the tailspin we've talked about. Probably the shrinkiest thing I will say here is the narcissistic injury. This is the person who says, I can't have cancer. I've taken great care of myself. There's no way. I can't believe that I now have cancer. It's not fair. How can this happen to me? Pain, spiritual crisis, other issues related to terminal illness. There are lots of other things that can mimic depression. That's why I think a formal screening approach is really helpful and important. There are a number of treatment options besides antidepressants. Medications are certainly something that's much more widely available than some of these things, but the best therapy is a combination of therapy. The psychotherapies, especially cognitive and cognitive behavioral therapy, really has a very robust evidence base of effectiveness, not only in depression in the general population and medically healthy populations, but in cancer patients, in patients with other illnesses. Cognitive behavioral therapy, which really takes the approach of examining the cognitions that patients who are depressed have. When you're feeling depressed, you generally have a pessimistic attitude about things, and you have what the cognitive therapists call automatic thoughts. These thoughts that pop into your head that are critical. I'm no good. I'm never going to do this. I'm probably, I'm not going to be able to finish my chemotherapy. I'm probably, my doctor's disappointed in me. I mean, when you start having those kinds of thoughts, that's a manifestation, a consequence of depression. So the cognitive behavioral therapies approach those thoughts directly. Let's reverse the thoughts. Let's analyze those thoughts. Let's come up with alternatives that reflect that more reflect the truth. And that's the general approach with cognitive therapy. It actually is incredibly effective, similarly effective to medications in many studies. Light therapy, particularly for folks who have seasonal affective disorder, who may be sensitive to sort of the shifts in day-night pattern. We've just sort of gone to daylight savings time, which drives those folks nuts. When you've got a major sleep disturbance, some programmed light exposure, to try to retrain that diurnal cycle can sometimes be very helpful. For severe and treatment refractory depressions, electroconvulsive therapy really is the most efficacious treatment, but it actually involves coming into a center and having an induced seizure under medical supervision. It's kind of a big deal, but it is really an incredibly effective therapy. The gold standard is combining therapies, and we'll talk in here for a second about the kinds of things that I generally would recommend to cancer patients who have a depression. I may use an antidepressant. I may also use some of the components of cognitive behavioral therapy. We may do some of those approaches that we talked about. Those generally require some training, but there's some components of cognitive behavioral therapy that everyone can offer to patients. Part of cognitive behavioral therapy is overcoming the pessimism that, it's just, what's the use? I might as well just sit around and do nothing. You can do something called behavioral activation, where you encourage patients, let's pick something that you know you're going to enjoy doing. You're reliably going to like this. You know that when you go to have dinner with your family, you know it's an enjoyable time. So you got to make yourself do that. You got to, even though the motivation isn't there, the depression has taken the motivation away. You know that when you go with your best friend to a movie that you have an enjoyable time. You know that if you'll just do it, you'll go and enjoy yourself. So you sort of have a homework assignment to do those kinds of things. Exercise. There was a really good study done at Duke University 10 years ago that looked at folks who had major depression and randomized them to treatment with initially with meds and then exercise. And the folks who got supervised group exercise had pretty robust responses to depression equivalent to antidepressant medications. So then they thought, okay, maybe it was just the group support. Maybe it was coming and exercising in a group. So they actually did another study where they randomized a cell of people to having exercise that was supervised at home. And they did the exercise, they reported that they did the same amount of exercise, but it was monitored by telephone at home, and both exercise groups had comparable improvements. So it really does look like even modest exercise can have antidepressant effects. So I'll counsel patients, we can try an antidepressant medicine, let's do some of these cognitive behavioral techniques, let's do some behavioral activation, I give them some homework to do something that they know they're going to enjoy, do some modest exercise, get some sunlight exposure, as long as you're not on a photosensitizing medication, but go out and get some exposure to sunshine and fresh air. And then I'll often give folks what I used to call hope homework. Find some things to hope for. I've got an entire talk on hope, so I'm going to condense an hour talk into about 30 seconds here. Hope, this is hope not in the sense of a wish, but hope in a more theological sense. Hope in the sense of something that I can count on and that I can look forward to with pleasurable expectation. So, I can't fairly say that I hope to win the lottery. I wish I would win the lottery, but I can't count on that. The odds of me winning the lottery are pretty slim. But I can hope that I'd feel good enough to visit with my children tomorrow. Or I can hope that I would feel good enough to enjoy a sunset over the bay tonight, okay? So those are the kinds of things, and hope has a very sustaining and healing effect. So we can actually coach our patients to have hope and to work on things that are concrete goals that they can hope for. So there's a range of things that we can do to augment antidepressant treatments that you don't have to have a specialist level therapists to do. So to antidepressant medications, do they work in cancer patients? There have been a number of clinical trials, most of them open label studies, that have pretty consistently demonstrated improvements in depression and subsyndromic depressive symptoms in cancer patients with a range of medications. But there's also, on the other hand, been a number of systematic reviews, actually kind of a ridiculous number for the state of the evidence base. They all basically say the same thing. There's not enough of an evidence base to say for sure. They're, again, sort of acknowledging that the trends and the studies that are available are supportive that antidepressants are helpful, but really and favor efficacy, but really not enough to draw conclusions. There was one study published in 2007 where they looked at patients with subsyndromic depressive symptoms, not a full-blown depressive episode, but also looked at comorbid symptoms, depression, anxiety, fatigue, well-being, and survival, and didn't really show any effect on those symptoms and associated symptoms with sertraline monotherapy, medications alone. Okay. How do I decide whether to treat with medication or psychotherapy, assuming you have psychotherapy available at your center? This is from the APA guideline. Milder depressions, patient preference, therapist availability, and patient stamina are things that sort of to factor into a recommendation for psychotherapy. It does actually require, to really benefit from some of these psychotherapies, the patient really does have to be able to attend. If you think about what a cognitive therapy session would be like, it does require some attention. Now, they don't have to be 45 minutes in duration. You can compress them into smaller chunks of time, but there really does need to be some capacity to attend. So someone who's really feeling fatigued, someone who's really having trouble with attention may not be able to benefit from this as much. You may move toward emphasizing antidepressant medicine if the depression is more severe, or for practical considerations like just not having the specialist level expertise available for some of the therapies. Very important to remember a couple of risks. The FDA has required a boxed warning on the labeling for antidepressants about the increased risk of suicidal thoughts in children, adolescents, and young adults. This does not appear to be a significant increased risk in older adults. And this was made a big deal of 5 or 10 years ago. I'll tell you, the main news about this is it's not news. It really doesn't appear that it's a drug effect. We've known for decades that when folks have a severe depression, and especially if they've been having suicidal thoughts, when they start to feel a little better if an antidepressant is beginning to work, they may actually just be motivated to act on the thoughts that they've been having. So it's not clear that this is an actual drug effect or just it takes some time for a depression to resolve. It is, regardless though, it is very important to monitor, especially when you're starting therapy, whether someone has new or intensified thoughts of suicide. It's also very important to ask if someone has never been treated with an antidepressant before, especially, have you ever had a time when your thoughts were moving so fast that it was a problem, or if you felt too good for your own good, or some sort of a screening question about mania or hypomania? Because if you have someone who has depression as a manifestation of bipolar disorder, and you give them an unopposed antidepressant, there is a risk of flipping them from the depression over into a manic episode. So especially someone who's never been on an antidepressant before, just a good question to ask them and or family members if they've ever had any symptoms consistent with mania. And if so, then you might think about a mood-stabilizing anticonvulsant or some other medication either instead of or together with the antidepressant. In addition to those two risks we just talked about, there's some drug-specific side effects, drug interactions, and I'd say the risk of neglecting non-pharmacologic therapy. This is kind of an artifact of how simple many of the antidepressants have become to prescribe. When I was working in hospice and palliative care, this was actually something that I saw an awful lot. It would be easy to get lulled into, well, this patient has depression, let's start them on a serotonin reuptake inhibitor. Okay, now we can move on to the next problem. Because the best treatment really is a combination of exercise, antidepressants and exercise and good sleep hygiene and basically just good self-care, along with either full-blown cognitive behavioral therapy or at least some of the elements of that. I think these are really not fire and forget smart bombs. They're kind of hand tools. And so it's really, you can easily get lulled into thinking that a prescription is really all you need to do. But you need to think about, if you're deciding about an antidepressant, what are the risks of not treating? Certainly, there is evidence that folks who have depression complicated by suicide, that leaving them untreated, if they have that severe of a depression, not giving them an antidepressant runs a higher risk of that symptom being persistent and having the risk of them acting on those thoughts. You may have prolonged duration of a depressive episode. About 20 to 25% of depressions don't go away on their own and become chronic problems. They often then become more treatment refractory. And certainly in depression that complicates grief, comorbid depression can make grief last much longer and be more problematic, carrying some of the physical consequences of all-cause mortality and sudden cardiac death that are increased with comorbid depression and grief. Which antidepressants should I choose? There are a number of antidepressants, a number that's 30 or 40 actually available for use here. And I think looking at our time, I'm going to let most of this stuff get covered in the things I have in the slides. But I do want to make, so there are psychostimulants that are This is an off-label indication for them. They're really not. They're used for attention deficit disorder, primarily, but for patients, especially who are in hospice care, who have a limited expected survival, they may be the treatment of choice in someone who doesn't have either a lot of anxiety or a propensity to delirium, because if they work, they're going to work right away. You find the effective dose, they may work that day as opposed to waiting 3 to 8 weeks for an effective dose to kick in. When you may not have that much time, then a stimulant trial is worth considering. There's a detailed protocol about managing stimulants in your handout materials, and so I would encourage you to consider those for folks who have a very limited prognosis. I want to spend the last couple of minutes skipping ahead and talking to you about a very important trial that was done a few years back called the STAR-D trial. So there's a lot of other information here that I'll let you look at in your slide set. The STAR-D trial, this is one of the times in the recent past when psychiatrists have behaved like oncologists doing research. We formed a multi-center collaborative group to look at an important problem, which is in the hands of expert psychopharmacologists, how often do antidepressants alone resolve depression? And I'll tell you a little bit of the background to this before we jump into a few of these studies. Most of the antidepressant drug trials use as their primary outcome treatment response, which is generally defined as a 50% or greater improvement in whatever depression scoring tool that you're using compared to baseline. But the clinically important outcome measure is not a percentage improvement, treatment response, it's remission. If you're treating me for depression, I want you to treat me until my depression is gone. I don't want you to take a victory lap when we're 50% less depressed. So the clinically relevant outcome is remission. And so one of the great things about this study, 41 different sites, greater than 4,000 patients, and they used as their primary outcome measure symptom remission. Depression is gone, okay? In most of the treatment studies, patients get response rates in the 60 to 65% rate. The sobering truth is that the placebo response rates are usually around 50%. So the difference between active treatment and placebo is actually kind of modest in most of the antidepressant drug trials. But even if you're looking at that response rate outcome, it's only about 60% of folks that respond to a drug trial. So what these folks did is they looked at second step treatment after treatment with a first-line serotonin reuptake inhibitor, citalopram, which is Celexa, okay? A standard antidepressant, available as a generic, in very common use. They took folks who had depression, they gave them an adequate treatment trial of an adequate dose for at least 8 weeks in the hands of an expert psychopharmacologist. So this is as good of an antidepressant therapy as you can get. And then the folks who failed treatment with this first line got one of 3 other treatments in the first study. They got treatment with bupropion, which is Wellbutrin, a different drug class that looks more at, it sort of aims more at dopamine and noradrenaline than serotonin. Some got on a different SSRI, same drug class, very different drug chemical structure, but the same drug class. And then some were randomized to venlafaxine or Effexor, which is a serotonin and norepinephrine reuptake inhibitor, so also a different drug class. And again, the primary outcome was remission. The sobering thing is, even in the hands of experts, 32.9% of folks achieved admission with citalopram. So only a third of folks got better after pretty robust treatment trials. Then they randomized folks to the other treatments, and we got up to therapeutic doses of the bupropion, sertraline, and venlafaxine, treated up to 14 weeks. And again, what they found is remission rates were, now these are again, are our folks who've already failed one trial, they already failed to respond to one trial. So, the folks that got better on citalopram are out of the study. They're done. These are the folks that didn't respond to citalopram. You still, for the second drug, you're still getting response rates in the 25% range. So this is 25% of the 66% who didn't respond. So we're getting a smaller and smaller population that are getting responses. They actually looked at augmentation studies as the sort of the next stage, where they added bupropion or buspirone to citalopram, and you got the same kind of a bump in remission rates. And the third paper really was, I think, the clincher. What they did is they looked at longer-term outcomes. They had folks who were going through serial trials. This is really what you do in real-world medication therapy for depression. They got serial trials where they got treated with one. If they didn't respond there, they got another treatment. If they didn't respond that, they got another treatment. If they didn't respond that, they got a fourth treatment. After 4 cycles, only 67% of folks got to remission. This is 4 cycles of up to 14 weeks of treatment. We're talking most of a year, and you're still only getting about 2/3 of folks to respond and about 1/3 who didn't. You've seen the ads on TV for medicines like the medicines that sort of boost depression, aripiprazole, those medications. It's really the result of this study that there are a lot of folks with depression that don't get to complete symptom resolution with medications alone. So it really underscores, even with expert psychiatric care, sequential switch and augmentation trials yield better outcomes, but a substantial proportion, up to 1/3 of folks, don't get resolution from medications alone, even in the hands of experts, even with these serial trials. So it really underscores the importance of a comprehensive approach to depression. And I would say that's, even though there aren't data about this in cancer patients, I'd say that's especially true in our patient population, that it has to do with maintenance of morale, it has to do with good sleep hygiene, just taking good care of yourself on purpose, applying some of those basic principles of cognitive behavioral therapy that you can use short of being a specialist expert, and weaving in antidepressant medication and other parts of the care for depression. I will stop there. Thank you very much for your attention.